Good afternoon or good morning, everybody. And thank you for joining us virtually today for our panel discussion on the COVID-19 pandemic and the activities going on here at the CU Anschutz Medical Campus. I'm Don Elliman, and I have the honor of being the chancellor of this campus and have the privilege of working with the people that you're going to hear from today. Since we last hosted a panel, obviously an awful lot's gone on. Lots happened. Vaccines have been widely distributed. Perhaps sporadically accepted by some, but anyway, widely distributed. We're looking to expand the age range of those eligible as soon as perhaps as this week or at the end of this month. Boosters are with us, and the expansion of booster availability may happen again as soon as this week. Today, what we want to do is share with you what we know and how that will impact us as we move forward. Before we begin, I do want to thank our donors in attendance. Your support has certainly helped us in these efforts in keeping us strong and allowing us to move forward. And we couldn't do what we do without you. So our thanks go to you. As we look ahead, we know that COVID-19 will be with us and shape our reality for the foreseeable future. We're really going to move at some point from pandemic to endemic, and that fact is with us, and we're aware of it. There's a lot of hope on the horizon, even as we focus on taking on the challenges that we see today. And our moderator and our panelists today are going to talk about that. We're very fortunate to be moderated today by the Dean of the School of Medicine and Vice Chancellor for Health Affairs for the Anschutz Medical Campus, Dr. John Riley. He will be joined by two people that, if you've been on any of the previous panels, you'll recognize. The first is Dr. Michelle Barron. She is a professor of medicine in the Division of Infectious Diseases at the CU School of Medicine. She's the Senior Director of Infection Prevention and Control at UC Health. And she's going to address new variants of the virus, as well as booster shots and vaccine availability for children. If you watched the news over the last, I don't know how many months, her face will be very familiar to you. She's become a rock star for us. And not far behind in his media appearances is Dr. Tom Campbell. Dr. Campbell is professor of medicine in the Division of Infectious Diseases and associate dean for clinical research at the CU School of Medicine. He has a specialty in the clinical trials of viral infections, including HIV/AIDS and COVID-19. He is the chief clinical research officer for UC Health, and he's going to share insights on variant strains of the virus and what the implications are for ongoing development of additional vaccines. While we have some questions already loaded for our panelists, we would also like to hear from you. Please share your questions in the chat window, and Dean Riley will address them as time allows. John, over to you, and thank you for moderating the panel today.
Well, thanks, Don, and good morning, everyone. Thank you for joining us. I'm always proud and happy to have the opportunity to share what's going on this campus, but I am actually sorry that we have to have this session today. I think a year ago, a lot of us hoped by this time with vaccines being on the horizon then and imminently released that we would not be in the midst of a pandemic still in the fall of 2021, but we are. And we're here today to take advantage of the expertise of Drs. Barron and Campbell to give you a snapshot of where we are now, give you some information about the vaccines, to the extent possible, make some predictions about the future, and then answer questions. I already see two in the Q&A, which we will get to before the end of this. So, Dr. Barron, I'll start with you. The Greek letter that's in the news these days is Delta. And at the same time, there have been aggressive efforts to roll out vaccination across the state of Colorado with some, as Don mentioned, geographic variability. So what has the impact of the emergence of this Delta variant been, and where do we stand right now in terms of the pandemic?
Yeah, thank you. And The Delta variant emerged probably end of May, early June. Unfortunately, Colorado was actually one of the places it was identified early on. The uniqueness of Delta, similar to what we saw with Alpha, is that it was much more contagious than what we now call the ancestral strain of COVID. And the reasons for that have to do with the amount of virus that it can produce, and just a thousand-fold potentially more than the ancestral strain, and allowed it to transmit much more quickly. Our vaccination rates obviously have been doing pretty well, but we did hit sort of a plateau. We're up to about 70% of all Coloradoans are now vaccinated. And people that are unvaccinated are what's still driving what we're seeing in hospitalizations and in terms of cases. 30% doesn't seem like a lot, but it is, especially when you have a variant that is this infectious that Delta is. And we know that people that are unvaccinated are significantly higher risk of acquiring the variant, getting sick and transmitting it to others. And so Delta really was the perfect storm in terms of transmissibility being much easier. And we were just not at that threshold of having enough people vaccinated, and especially people that are younger, which is the other thing that we've seen over the summer and into the fall, is that who's getting infected with this tends to be people that are younger. The people that got the vaccine in the early stages seem to have a level of protection.
Thanks. And so speaking of vaccines and the level of protection, Dr. Campbell, can you speak to the effectiveness of the RNA vaccines, Moderna and Pfizer, as well as the J&J vaccine when it comes to Delta? And probably rather than wait, it's a good time to address the question of boosters or additional doses and the timing and impact of those.
Yes, glad to. So when we talk about how well vaccines are working, we have to first remember what the vaccines were intended to do. And the vaccines for COVID were designed to prevent severe illness. So the real purpose of these vaccines is to keep people from getting so sick that they have to be hospitalized, put on a ventilator, or potentially die from COVID. And so that's the main thing we want to accomplish with these vaccines. It's great if vaccines also prevent infection and prevent spread to others, but those were not the original intent of these vaccines. And then the second thing is we have to also think about how we measure those effects. And we can measure them in research studies such as clinical trials, or in effectiveness research studies as the vaccines are being used. And we can just look around our own state, our own hospitals, and see how they're working as well. So what I can tell you is that the effectiveness of the vaccines does diminish with Delta. Vaccines such as the mRNA vaccines, Pfizer and Moderna's vaccines, in the parental strains, their efficacy and effectiveness was in the 90+% range, 93, 94%. And what we've seen with Delta is that decreases to the 85% range for preventing symptomatic illness, but still very highly effective in preventing hospitalization and preventing death. Johnson & Johnson's vaccines all along have, it's a single dose vaccine, and it's been slightly less in effectiveness compared to the mRNA vaccines. And with Delta, we see that the vaccines are still working well against hospitalization. If we look in Colorado, 80% of people who are hospitalized in our state are unvaccinated. Here at UC Health, 84% of people hospitalized with COVID are unvaccinated, and 95% of the people who are on ventilators in our intensive care units with COVID, 95% are unvaccinated. So we see evidence right before us just how well these vaccines are still working even against Delta. Now, in terms of boosting, there are emerging data that show that boost will work even better. So there are data being discussed by a CDC advisory panel today from Johnson & Johnson that show that a boost, an extra dose of their vaccine increases their efficacy from the 70% range to the 94% range. And there's a press release from Pfizer just today with results from their clinical trial that show against Delta that vaccine efficacy goes from 80% against Delta to 95% against Delta when a third dose of the Pfizer vaccine is given.
So thanks. There's a question in the Q&A that relates to what you were just saying, Dr. Campbell, and that is any data about boosting, might be too early, I guess, but of these boosters preventing or reducing the incidence of long COVID?
Yeah, I've not seen data on that for boosting. We do know that people who are vaccinated with, say, 2 doses of an mRNA vaccine can still get long COVID if they get COVID. I don't know if the vaccine reduces the rate of that, but it does happen. I've not seen any data yet on the effects of boosting.
Okay, so question for you, Dr. Barron. The population that's in the news and a clinical trial we participated in on this campus has to do with vaccinations in kids aged 5 to 11. So can you talk a little bit about the controversial issue of masking in schools, as well as what the perspective on are vaccines going to be available for school-age kids and your recommendations around that?
Sure. So I'll start with the vaccine itself. Pfizer has conducted studies in this age group, has submitted the data to the FDA, which approved the initial review of the data in terms of allowing an emergency use authorization. The next step is the ACIP, which is the Advisory Group on Immunization Practices. We'll meet to discuss the data. That's going to occur next week, I believe, next Wednesday, Thursday. They have it scheduled to discuss the data and to make formal recommendations regarding the vaccine efficacy in this group, as well as potential for side effects or adverse events in this age group as well. It is a different dose. It is not the same dose that has been given to adults. And so there'll be a whole different manufacturing process for the vaccine for kids from 5 to 11. The data looks quite good. It looks like it does what it's supposed to do. And again, not a lot of serious adverse events. It'll be helpful for the ACIP to be able to distribute that data and information more broadly so that everybody can make that decision. But I will say that it is obviously an important factor now that kids are in school, that they have access to the vaccine, and it protects them. And in the masking piece of things, masking is highly effective. There's now more than sufficient data to show it works. It's a good thing. Anybody that has school-age children know kids bring stuff home all the time and they get sick frequently. Masking is a good way to prevent that from happening. There is a lot of controversy around this issue. There are mandates in some school systems and not in others. And I think it becomes really, there's a lot of interesting things that have been spoken related to the use of masks. I will say masks work. Again, getting your kids to wear them. Kids are actually pretty much more resilient than I think adults are in terms of change. And having some children in my family, not in my own personal household, and I asked some questions about this, most of them don't really care. You just tell them what to do, and most of the time they follow the rules pretty well. And I think having the masks in place prevents schools from having to shut down or having to have classrooms go back to remote learning, which was really challenging for everyone. So I think they are good things. I think they are protective. It also will help protect them against other types of viruses. We've seen a lot of respiratory syncytial virus circulating. We're heading into the fall where we're probably going to see flu. And in addition to vaccination, masking is a good thing.
Okay, thanks. I'm going to direct this one to Tom Campbell. There's a number of questions in the chat, and the theme is sort of mixing and matching vaccines. If you got the J&J, can you get a Moderna or a Pfizer booster? If you got Moderna, can you get a Pfizer booster? We can do all the combinatorial things here. What's the current thinking about that? I will leave that question at that.
Yeah, so that's an excellent question. The short answer is if you want to get a booster, you can get whatever you want. The FDA has authorized mixing and matching of boosters. I guess the real question is, should you get something different? And what I would say is the data that we have so far does not indicate that there is increased effectiveness or efficacy in preventing COVID illness by mixing and matching with a different booster. We do know that immunogenicity is a little bit different. There was a nice study that's been put out in a preprint form that shows that if you use the Moderna vaccine as the third dose, you get higher antibody levels. But antibodies aren't the whole story. They're part of the story. And whether or not you get sufficient difference in protection, we don't know yet. What I would say, though, is that there are potential side effects from these vaccines, and mixing and matching could potentially increase the risk of those side effects. We don't know that yet. I think the safest thing to do is, if you've tolerated a primary series of any of the three vaccines well and not had major side effects, is to stick with that same vaccine for your booster dose. That way you'd have the lowest risk of having any serious side effects.
Thanks. I'm going to direct this next one to Dr. Barron. There's a question in the Q&A. So for a fully vaccinated person who's received a booster, but who's on immunosuppressive medications, what are the recommended precautions, and what's the role of antibody testing to look at the immune response?
Yeah, so as Tom just kind of alluded to, antibody response is not the kind of end all be all in terms of whether or not your immune system is adequately protecting you. And so we have not recommended routine testing with antibodies, even from the beginning. I think a lot of people, when they got their initial shots, that was one of the things they did, was to see if they had titers, and that was either reassuring to them or less reassuring to them. And I think we still just don't have enough data, conclusive data, to be able to say what the antibody titers reflect and whether or not that really is a good measure to be able to say whether you're protected. If you're an immunocompromised host and received your third dose of immunization, I think that's a really great start in terms of keeping you protected. I think you, depending on your level of immunocompromise, because there's a full variability with this from, the utmost, if you're a transplant person versus certain medications that impact only parts of your immune system. I think you want to just still be conscious that Delta is circulating. There could be other variants. You can certainly, all of this becomes an individualized risk in terms of thinking about what thresholds you're comfortable with. There are ways to minimize risk by masking, washing hands, not going to large events where there's hundreds or thousands of people. But I think a lot of this comes back to, you've done the right thing by getting vaccinated. I don't know that we can say on an individual level where that puts you, because there's a lot of variables. I would not get an antibody test. And I would still be smart in terms of just thinking through how comfortable I am or not, how you are with the situation that you're going into. And are there things that you can make it more likely that you're not going to be exposed? So, everybody that you're going to be around, is vaccinated, or you're doing things still outside, or we're limiting it to the number of people that I'm exposing myself to. Or I wear a mask if there's going to be more than 10 people. Those are all things that you can consider, but it's hard to be able to say for one specific person, this is the right or wrong answer.
John, if I could add just
Yeah.
something real briefly, just to put in a plug for a research study. So we will be starting on this campus very soon, meaning the next couple of weeks, a research study to evaluate whether giving a monoclonal antibody preparation, the one that's made by Regeneron, to people who are immunosuppressed and do not have detectable anti-spike antibody, whether that will help protect them against COVID. So this may be something that will come in the future, is that for people who don't respond to vaccines, we all are very sad about the news of Colin Powell just this week. But people like Mr. Powell who are immunosuppressed and don't respond, getting a monoclonal antibody might help protect them. And that's the purpose of this study.
Okay, so I'm going to forewarn Dr. Barron here. I'm going to ask her a mask question in a minute here. But while I have you off mute, Dr. Campbell, there's a question in the Q&A about the transmissibility of Delta among people who are vaccinated. There's been some press about whether there's a difference in viral load and whether they can infect other people in the same way an unvaccinated infected person might. What are the data about that?
Yeah, so when we measure viral load, what we're measuring is the amount of viral nucleic acid, RNA, in the upper respiratory tract. And what we know is that when vaccinated people get infected, soon after they're infected, when they're diagnosed, they have the same amount of viral RNA in their upper respiratory tract as someone who was not vaccinated. But we don't know if that is all infectious virus, and we don't know if the amount of actual infectious virus differs between those who are vaccinated and those who are not. We do know that the amount of virus or the amount of RNA that's shed decreases faster in people who are vaccinated. So we do think that there is evidence that people who are vaccinated are less transmissible, not zero transmissible, but less transmissible than people who are unvaccinated.
Thanks. So now, Dr. Barron, the uncontroversial mask questions. So there's a couple in the chat and the Q&A. One is mask works, but how long should people be in masks? I mean, how for kids and adults? And the second is, this is probably one for the chancellor. Since 99.5% of the people on the campus are vaccinated, why do we have to wear masks?
All right, so the question with regards to masks, there is actually some data. So back when we were preparing for pandemic flu and looking at, we wear masks in the hospital pretty consistently for a lot of the different things that we do. And there were studies conducted in sort of preparation for a pandemic, at the time thought to be flu, of how long people could reasonably wear masks. And a lot of that came down to the type and how long would you be comfortable, were there side effects, ill effects, et cetera. And a lot of it came down to the type of mask that you were actually using. So surgical masks, and now we obviously have cloth masks as well that are used pretty commonly in the community. When they're comfortable and well sealed, you can wear them for as long as you need to. There's never been, and again, there's going to be some individual variation. In the studies that we did in healthcare workers, they can tolerate the surgical masks for their whole shifts without any ill effects or any kind of compromise. When you start wearing respirators, that's a little different. And then we certainly saw in some of the studies that we had conducted that having those on for prolonged periods of time when they're appropriately put on, so not below the nose or over the chin, where they're adequately sealed. There was time frames in which people started to feel the effects of wearing the respirator and started to have some complaints of like headache or feeling of more shortness of breath. A lot of this was subjective, obviously. But again, no obvious, sorry, my light just went out. No health effects that we knew of in terms of using them for prolonged periods of time. And so I think having them in schools, they take them off when they eat or drink. the key is the comfort level for the individual that's wearing them. And if they're not comfortable, they're either not going to wear them, or they should probably get a different one that works for them and it still has the impact that it's supposed to have.
John, I'll take a stab at the
Yep.
why. So on campus, for those of you that are not here, we do require mask wearing when you're in close proximity to others. And even though we have over 99% of the people on the campus already vaccinated. And the reason is actually advice from Drs. Campbell and Dr. Barron, which is that you still can get, as Tom just talked about, even if you're vaccinated, you can still get the virus, you can still transmit the virus, as far as we know. And we have seen some outbreaks on the campus. They've been contained, and we've limited the downside by having people be vaccinated. They tend not to go. Very few. I don't know of any that have gone to the hospital yet. But we're just trying to be better safe than sorry. And as a health science campus, we're trying to follow the best rules that our leading scientists can give us. So we have no immediate plans to change our masking policy.
Okay, thanks. So I'm going to direct this next one to Dr. Campbell, since you led a lot of the vaccine trials. A couple of questions about potential side effects of the currently approved vaccines. Can you address the myocarditis issue and the incidence of myocarditis relative to the risk of severe COVID infection, particularly in younger adults? And also, there's a lot of stuff in the popular press and on the internet about impacts on fertility. And the use of vaccines in pregnant women, can you comment on that as well?
Yes, glad to. So, although we say that these vaccines are safe, they do have side effects and they do have risk. And most of the side effects, fortunately, are minor and transient, things like flu-like illness, muscle soreness, maybe some fever. But there are more serious side effects, and myocarditis or pericarditis is one of them. We've only seen an increased risk of pericarditis and myocarditis with the mRNA vaccines, so just the Pfizer and the Moderna vaccines. And the risk is most elevated in younger men, and so men between the ages of 15 and 30. And in that age group, the risk is somewhere on the order of about 30 cases per million doses of vaccine. So 30 per million is a real number, but it's a very small number, fortunately. There's also evidence that is being presented to the CDC advisory panel today that the risk is slightly greater with the Moderna vaccine compared to the Pfizer vaccine. So that we do have that risk, but COVID causes myocarditis as well. And actually the risk of getting myocarditis if you get COVID is greater than the risk of getting myocarditis from a vaccine. So in balance, the benefits of the vaccine outweigh that risk. Regarding fertility and pregnancy, so there's no evidence that these vaccines affect fertility. In fact, during the clinical trials of these vaccines, participants, although they were supposed to be practicing contraception, some participants did conceive and become pregnant. And there was no difference in the pregnancy rates in the placebo versus the vaccine arms. So the vaccines had absolutely zero effect on fertility. Now, in terms of effects on pregnant women and their unborn babies, what's important to know is that that pregnancy itself is a risk for severe COVID. So women who are pregnant are at higher risk of dying. It's almost a threefold greater risk of death if they get COVID compared to a non-pregnant woman. There's a greater risk of stillbirth, also about threefold, and there's almost a fivefold greater risk that their baby will end up in the neonatal intensive care unit. So there are serious risks of getting COVID if you're pregnant, and being vaccinated will reduce those risks substantially. And so we do have data on safety in pregnancy and adverse outcomes during pregnancy, things like miscarriages, stillbirths, early births, premature births. There is no difference in the rate of those events in women who are vaccinated versus women who are not vaccinated. And this comes from a very large database of over 125,000 women who have been pregnant and received the vaccine here in the US.
Thanks very much. As we read the national news, Dr. Barron, we see that nationally the rates are going down, that we're down to 1,600 deaths a day, which would have been unfathomable 2 years ago. But we're not seeing that in Colorado. And so, using your crystal ball and gazing ahead over the next few months, yeah, there you go. What does this current wave look like, and how long is it going to last?
I should have asked my magic 8-ball so I could have the right answer. I think there's a couple of variables in play here that I think are important to take note. So the national trend obviously is going down, but it was also driven previously by Florida, Texas, Mississippi, et cetera, who were having unbelievably high rates of COVID and also had it's actually opposite, low rates of vaccination. I would say high rates of unvaccinated individuals. So there was a lot of, those numbers were certainly conflated because of the population density and the lack of vaccination. So the cases were running wild. In Colorado, we had never saw that same type of sharp upswing in terms of number of cases. We are at the highest rate of hospitalizations that we've been at compared to December of last year. And so we didn't see sort of the incredible upswing, but we are trending up. We're still nowhere close to the rates that we saw in these other states. That being said, a lot of this is looking at models. A lot of the models obviously have useful information, but aren't always necessarily as predictive as we'd like them to be. Based on the current models that we've seen, we will continue to have sort of this upswing, but we're already kind of on a plateau. The upswing is really a number of, 10 people, 12 people in the hospital, and percentages sort of fluctuating sort of 1% to 2%. So not, again, huge up or down. The model suggests we will plateau, start to downtrend, and then after the Thanksgiving holidays, potentially see another surge. I think obviously it's COVID. We don't know. There can be a new variant that could be worse or potentially not as bad as Delta. I think travel, the holidays are always times where we see potential more cases. Some of it because people are tested, so that's obviously part of the equation. And mostly though, because people are gathering. With the weather getting cooler, there will be more indoor activities potentially that can help spread this more. Again, vaccination is still a huge tool to this, and we're at 70%. Can we get to 80, 85 and make that difference in terms of the number of cases? I think that remains to be seen. But I think transmission control is still, with vaccination, is still probably the most important tool we have moving forward, and getting your flu shots. If you've got your flu shots, we want to make sure we don't have a flu year. And one of the questions in the chat regarding whether or not we're going to see flu this year, since we didn't, I think we will. I think the fact we don't have mask mandates and that their kids are in school and travel is relatively less restrictive, I think we will potentially see flu play into this as well, and make things very complicated from a COVID standpoint, since the symptoms overlap significantly.
Okay, thanks. So Dr. Campbell, Dr. Barron mentioned the potential of new variants emerging. We've been talking about Delta we were joking in preparation for this panel about reacquainting ourselves with the Greek alphabet, with mu and other variants out there. So can you speak to the prevalence of these other variants, and are there something that we need to be worried about? Is the approach for them any different than what we're doing now?
So these other variants that you've mentioned are things that we do need to keep an eye on. They're not of immediate concern because here in the US and in Colorado, virtually 100% of all new infections are Delta. And some of these variants, Alpha, Beta, Gamma, they were already here in the US when Delta arrived, and Delta overtook them all. Now, there are other variants that have been described in different parts of the world, Mu in Colombia, Lambda in Peru, Zeta in Brazil. But so far, they are remaining contained in relatively small amounts in these discrete geographic areas, and they've not spread worldwide yet. We do need to keep our eye on them because there is evidence that they are more resistant to the immunizations that we have. So there's less protection from the vaccines compared to other strains. But we also have evidence that boosting provides better protection. In some data that I've seen from Johnson & Johnson clinical trial, when they looked at mu specifically, which again is in Colombia, with a booster of the J&J vaccine, the vaccine efficacy went from 36% to 63% against mu. So the vaccines, particularly with boosting, still do work very well against these other variants that are emerging. I've also seen in the news recently that in England, there's a variant of Delta that is now emerging in a small amounts in England. They estimate that it's 10% more infectious than the Delta that we're all dealing with right now. So it's not just the resistance to the vaccine that's important, but it's also how infectious these variants are. We know that Delta was more infectious than Alpha, and Alpha was more infectious than the original Wuhan strain. And that really is what has contributed to Delta's ability to essentially overtake all of the other variants.
Okay, so this one is for Dr. Barron. If memory serves, last spring we were having a conversation, and the issue of whether people were going to need boosters in the future came up, and you predicted we would, and the data has emerged that we have. Some of the questions in the Q&A are for people who've gotten the booster, how long until the next one, if there is a next one?
Yeah, that's $1 million question that I don't think we have the answer to yet. I think a lot of that will depend on how much COVID is still circulating. If we were managed to have it become more what we call endemic versus pandemic, where it continues to occur at a lower rate and still affects individuals, but would be more like the flu or a common cold than what we're seeing now in terms of the impact on hospitalizations and resources of health. And then, you know, the question that I think that is out there that obviously is still we're watching is with the variants. Will it come a point where the current vaccination that we have available is no longer effective and we have to reformulate the vaccine for a new strain or a new variant that is causing or wreaking havoc? So I think all of those things are the things that we don't know the answers to yet. And we will obviously know sooner. The booster question, I don't think was as hard a question, thinking that we might need a booster. I don't think that was as hard, only because of looking at just the immune system and the natural ability for us to respond to respiratory viruses. The immunity of that is not mostly is not lifelong, or but there's also the changes that play into that. So I think that was an easier one to predict. This one, I think, I'm not sure I have as good intel. Tom might have more insight than I do.
No, I think it's purely a guess at this point. You know, we refer to these extra doses that people are getting now as boosters, but the reality is that this may just need to be a 3-dose vaccine series. And there are other viral vaccines, hepatitis B is an example, where it's a 3-dose series, day 0, 1 month, and 6 months. And so that just may be the case for COVID vaccines as well. We will have to see what happens over longer periods of time.
So while I have you off mute, and while we're on the subject, can you talk a bit about other vaccines? You know, we have the Moderna, we have the Pfizer vaccine, we have Johnson & Johnson. Can you talk a bit about other vaccines under investigation and where those clinical trials stand?
Yeah, so here in the United States, in addition to the 3 vaccines that we currently have, of course, Pfizer has full licensure, a BLA, as we call it, from the FDA, and Moderna and Johnson & Johnson are under emergency use authorization. There are 3 other vaccines that have conducted clinical trials, phase 3 clinical trials in the US, and are sort of a little further upstream in the pipeline. And those are AstraZeneca, Novavax, and Sanofi. And so AstraZeneca, people may know, is being widely used in Europe, particularly in the UK. And they do have data supporting the efficacy of AstraZeneca vaccine here in the US. They have submitted their data to the FDA. Novavax also has conducted clinical trials worldwide as well as here in the US. They are planning to submit their data to the FDA very soon. And then Sanofi Pasteur has a vaccine that is still in phase 3 clinical trials. So my best guess is that maybe by early 2022, 1 or 2 of these 3 vaccines might be authorized here in the US. And then 1 or 2 more coming in the next year or so. So there'll be more options out there for people to choose from.
Thanks. Before we run out of time, Michelle, I wanted to get you to address one of the questions we talked about in advance and that's appeared in the chat, and that is, what should people be doing over the holidays? What kind of masks to wear if you're going to travel? Should you travel? You alluded to a little bit of this earlier, talking about social gatherings, but what kind of practical advice would you give people thinking about, you know, Thanksgiving and the end of the year Christmas holiday season?
Yeah, so for us, starting with the travel piece, just in general, obviously there's different modes of travel, and some involve public transportation and some involve your own personal transportation. I think that's the first thing you want to think about in terms of what makes sense for you and the people you're traveling with. There are still federal mandates regarding masking, and so everybody in airports still has to wear masks. The type of mask, I would tell you, really depends on what feels good and fits well. The most important thing with masking is that you have a well-fitting mask that seals appropriately and that you'll leave on and you're not fidgeting with, because I think that's half the battle, is not moving the mask around or touching your mask frequently. And so I wear surgical masks. My husband wears a KN95 when we've traveled. It's sort of a preference in terms of what fits our faces and what we feel. I didn't feel there was a difference in terms of efficacy on the planes themselves. The other part of travel importance is know where you're going and what the restrictions are there. Every state is different and counties are different in terms of requirement of masks when you're out and about, needing to show a vaccine card if you're going to restaurants or you're going to public forums. And so you want to be able to know that ahead of time so you don't show up on your vacation or to where you're traveling to see family and friends and then realize you don't have your vaccine card or you don't have enough masks for the duration that you're going to be there. In terms of the should you travel or not, I think that again becomes a decision that's important to make on the individual level and what makes sense for your household. I will certainly give my bias that if you are unvaccinated, you are high risk of getting COVID and you can spread it to whomever you're going to be around, as well as potentially be stuck where you're at if you got COVID. So my plug is still to get vaccination. If you haven't, if you're due for a booster, get your booster. And then this is where it becomes, again, decisions that have to be made from a household and personal decision with regards to gatherings. I will not allow people that are vaccinated and not vaccinated in my house, period. And that is my personal decision that may not work for everybody. Certainly even within my family, there are individuals in my family that are not vaccinated and they understand they're just not allowed in my house. And that's just, again, things that have to be negotiated. So I recommend that as well. Like if you feel strongly about, having to have vaccine or masking requirements because of vulnerabilities in your household, or if you have kids that you're trying to protect, those are the things that you probably want to talk about before you arrive at your destination. And so the CDC does have some great information on travel advice every year. I think those resources have been vetted and can offer you some good ideas. And I think it is safe to travel. It's safe to travel with kids. I think you, again, just have to keep in your mind, what are we going to be doing? What are the activities? And is the risk benefit ratio of doing the activity versus maybe the risk of getting exposed to COVID worth it? And I think that's an answer that we will continue to all be grappling with till COVID sort of settles itself out. Dean Riley, you're still on mute there.
I'm going to address this next one to the both of you. It's the last question in the chat. So you both are members of the Division of Infectious Disease in the Department of Medicine. Are you going to have a holiday party? And if you do, would you go? And I'm assuming we actually know that all of you are vaccinated.
So I can start, Michelle, but I would say first that Michelle is the infection control expert in this room, and so I will defer to her, but I'll give my opinion first. So actually, John, this question was actually posed to me by one of another Department of Medicine faculty member just last week, not in infectious diseases, but it was concerning a holiday party. And my response was that a couple things to consider were, what is the chance that someone would be at that party who is infected with COVID? And right now, the epidemiologic data indicate that about 1 in 160 people in Colorado are currently infected with COVID. So if you have a big holiday party with 200 people, there's a very good chance that there'll be at least one person in that room with active COVID. And then the second question is then what is the risk of that to the other people? And yes, vaccines protect, but they're not 100%. And as we've been talking about, and as I mentioned was unfortunately exemplified with the death of Colin Powell, is that for some people, the vaccines don't work as well. And so, if there's a chance that in those 200 people that there'll be someone who's immunosuppressed and from whatever condition, and we know that about 2 to 3% of people in the United States meet the definition of immunosuppression. So if you have 200 people, there's a good chance that there'll be some people who are immunosuppressed and the vaccine will not work, and they will be at risk of very serious outcomes. So in the short answer is, my advice would be to avoid those type of large gatherings, given the current frequency that that COVID exists within our population.
Yeah, and I echo what Tom said. Those are the considerations that we're looking at as well. Certainly, you can imagine I get a lot of questions about this. And from a UC Health system approach, we broke it down into different types of gatherings, being indoors, outdoors, the size of the gathering, if it's less than 10, 11 to 50 or over 50. And then, and also the transmission rate in the community. Right now, the transmission rate in the community is still pretty high. And so most of the events that we have discussed having, if at all, most of them have been no's. I'm like, nope, can't do that. Nope, can't do that one either. And again, I think that's, it could change. I haven't said no forever, but a lot of it just depends where we're at. And with community spread still being pretty high and the statistics that Tom just gave you, that's part of that equation. And certainly from UC Health standpoint, we strongly believe we have to model what we're doing. So we don't want to be the ones that said, oh yeah, well, it doesn't apply to this particular group. And then we have an event where people get sick. That is not our goal. Our goal is to preserve health. And certainly with me being infection prevention, prevention is my key here. And so it can be from personal decisions. Again, if it's not associated with UC Health, people can make those decisions. But I think as a health system, we have taken that approach of we have to walk the walk. And it's not always fun to have to tell people you can't have this event as exciting or interesting or fun as it appears, because there's just too much risk. As an individual, you can make that decision, but from the healthcare standpoint, that's how we've got sort of approached this.
All right, so I'm going to put you on the spot here because the last question in the chat. So hypothetically speaking, because of your reputation as an infection control expert, if the owners of the Denver Broncos called you up and said, what do you think about 60,000 people in Power Field, what would you say?
So I have to have full disclosure here. I actually do consult for the Broncos. And so they don't ask me about field questions, but they do ask me my thoughts on these things. And I think this is the balance of from an economic business standpoint versus a public health versus an individual decision. I'd say my role in infection prevention is easy in the hospital side, and that it makes sense to us what we do, because the individuals that come into the hospital don't have a choice. You don't come in because you want to hang out in the hospital. You have illness or something that compels that. Nobody is compelled or has to go 60,660, whatever you want, whatever number you want to choose. Nobody is compelled to some people might argue with me on this. Nobody is compelled to have to go to a game. And so I think they do have a lot of measures in place at the field to make air handling, hand sanitizing stations, UV lights in the railing. They did a lot of work in the stadium itself to make it safe. At the end of the day, it's your decision if you're going to attend. If you're unvaccinated, know your risk is higher of acquiring something or potentially spreading it. And then the mask piece becomes, again, sort of how comfortable am I in terms of going or not. And so I have had these discussions with several of the sports teams, and personal, sort of the thought was, okay, at some point people have to make personal decisions of whether it's a good idea if they want to come, and they have businesses to operate that counterbalance. They can make it as safe as it can be, and then it's your decision whether or not you want to go.
Okay, so we're nearing the end of the hour here, and I wanted to give both of you the opportunity to address any topics you think people should know about that we haven't touched on this morning. I heard Dr. Barron, and I assume Dr. Campbell feels the same way. Give a plug for everybody getting the flu vaccine in addition to the appropriate COVID vaccine. But are there any other things that you think the interested audience here should know before we sign off?
I guess what I would say, John, is that I think I want people to realize that COVID is here to stay. And, you know, that's a prediction on my part. I can't say that for sure, but I think the evidence is that COVID will become the 5th human coronavirus that stays with us for many, many hundreds or thousands of years to come. And so we have to continue to grapple with these questions, as, you know, as Michelle has explained, and, you know, in the risk involved. I think that as we develop more immunity in our population, that's not going to make COVID go away, but it will decrease the risk to people of getting severely ill from COVID. It will decrease the burden on our healthcare systems, and it will make people more comfortable getting back to the life that we knew before January of 2020. But I think we have to realize that it's not going to go away, that we will probably all get infected with COVID at some point in our lives if we live long enough, even those of us who have been vaccinated. But for those of us that have been vaccinated, it will hopefully be a mild self-limited illness. Those who have chosen not to be vaccinated will be at a much greater risk of getting severe COVID. But I think given the infectiousness of Delta and the possibility that even more infectious variants will come our way, it's going to be something that everyone will experience at some point.
The only thing I want to add on, I agree with what Tom said, that Delta is here to stay. And sort of in that vein, we will continue to adapt, we will continue to innovate. And I think this is, as much as we complain and we tell people we're tired, these are still incredibly exciting times we're living in terms of the pushing science forward and pushing a lot of the things that we hadn't done before. And so I think I'm definitely one of the half glass full people, but I think that's important to remember, like, for how much progress we have actually made. And where we're not out of this, we are still doing incredibly, we have vaccines, we have all this cool stuff we didn't have before. And so the impact on society at large will be felt in many ways, but I like to think of all the positive things that have come out of that. And keeping that in mind, things will continue to change. That is the one thing I can predict with certainty, is that they will continue to change. And so make sure you're getting good resources for your information to make sure when these changes happen, that you're really following the science and not a lot of the bad stuff that comes out that actually has no basis in science.
So I want to thank both of you. I'm going to turn the podium back over to our Chancellor, Don Elliman, now, but I do want to put a plug in to build on Michelle's theme here. This is an incredible scientific success story. To go from a epidemiologic observation to the widespread dissemination of highly effective vaccines in under 2 years is unprecedented in human history. So for those of you here in the audience who get your care here on this campus, if you're offered the opportunity to participate in clinical research, I would urge you to seriously consider it, because that's what moves the field forward. And with that, I'm going to relinquish the floor here to our Chancellor.
Thanks, John. And let me add my thanks to not only you, but also to Dr. Campbell and Dr. Barron. You know, we've had you on these panels for the last year and a half, a number of times, and I think you've provided really invaluable advice and counsel and information to our audience. So thank you very much. As you know, or if you've followed the Q&A line, there have been more questions than we've been able to answer today, and we would encourage you to look at CU Anschutz newsroom, or at the CU Anschutz newsroom, which is news.cuanschutz.edu for the latest information on our campus response to COVID-19. We will circulate a link to the newsroom along with a recording of today's panel as a follow-up. With the fall and soon to be winter upon us, be well, be safe. Thank you for joining us today, and God bless you.